Thank you for the introduction. So I'm going to focus in this talk around vasoactive drugs and look at the evidence to guide which drugs we should use. My conflicts and acknowledgements you've seen before, and they stay the same. And as I said, the views expressed are my own, not those of the NIHR, the Department of Health in the UK. So if we want to know what vasopressor we should use, we could look to the meta-analysis. This Cochrane review was done 2 years ago now. And it's compared norepinephrine versus multiple alternatives, which you can see here in the sort of standard forest plots. But what it's done, that more and more analyses are doing now, and I think is really useful, is this Bayesian network analysis, where even if two drugs haven't been directly compared, they may have been compared against a third drug, and you can bring them together in this network and try and work out what drug might be the best option. So they've done that within this analysis, and you can see everything is compared to norepinephrine as the comparison. And you see at the top, dopamine is suggesting it has a worse outcome than norepinephrine. Confidence intervals just crossing 1. And then if you look at some of the other drugs at the bottom, they've separated out terlipressin and vasopressin. Actually, maybe some signal, again, confidence intervals clearly crossing 1, suggesting they may be beneficial. So these reviewers concluded that there isn't clear evidence of one drug being better than another, but they do suggest, because of the side effect profile of the dopamine, where we saw in the SOAP study that there was higher rates of atrial fibrillation, VT and VF, avoiding against using dopamine. So that seems clear that we shouldn't be using dopamine as a vasopressor, and that we'd be using norepinephrine. But what about the evidence compared to other drugs? So this French study was comparing norepinephrine with dobutamine versus epinephrine, so that you still got a beta effect if you needed it in the norepinephrine arm where you could add in dobutamine. And this trial showed that there was no statistical difference between the two treatment arms, although do notice it's 6% lower in the norepinephrine group, but as I said, not statistically significant. So these authors concluded that there was, again, no difference between these two drugs, and there was no difference in their safety profiles. But I would say I think it's a small study, and when you look at the power calculations, they were powered to detect an absolute reduction in mortality of 20%. So if you remember, it was 40% in the adrenaline arm. They were talking about halving it. And I think it's right to get the right drug to treat your hypertension, but I don't think it's going to halve the mortality by choosing which vasopressor you have. So I think, unfortunately, we're still, this is an underpowered study and limited the evidence that we can draw from it. But I think there is useful information still in it, and that is the well-known, well-described pharmacological effect of giving epinephrine that does lead to a lactic acidosis. Now, I'm not sure that that per se is a bad thing. There is some evidence even that the lactate may be good as a metabolic substrate. But I tend to use lactate as part of my resuscitation goals. And if I give epinephrine and the lactate then goes up, as they've shown as it did in this trial, it makes it complicated. Has the patient got sicker, or have I just started the epinephrine? And it's difficult to tell. So that's one of the reasons why I prefer to use norepinephrine rather than epinephrine. What about other drugs? Well, there's no big trials of phenylephrine, but this study came out last year. It was a sort of almost accidental RCT. It's not randomized, clearly. But you see there was a supply shortage in the United States of norepinephrine. Some hospitals ran out. At the bottom here, you can see where there was a shortage period. They used less norepinephrine and had to substitute something else, and it was mainly phenylephrine. Some hospitals had enough in store, and so their effects didn't change. And this group have looked at outcomes in this period, and they compared the patients who were in the shortage period to a baseline period in those same hospitals, and they found, even when adjusting for illness severity, mortality went up in the shortage period. They compared between hospitals that did and didn't run out, and again, in the ones that ran out, mortality went up when they changed the vasopressor. Now, they tried to see, was there anything else that changed? Because clearly, as I said, it's not randomized. And when they look at the patients who just had sepsis without shock, there was no difference. These are the bottom two. There was no different outcomes. So again, it would suggest that we probably should keep on using norepinephrine. I don't know that the phenylephrine is harmful, or maybe it was just they weren't so familiar with using the drug. But I think, again, it supports using norepinephrine as our first-line therapy. So that's about catecholamines. What alternatives? Well, this meta-analysis has taken all non-catecholamine therapies and compared them in a meta-analysis, suggesting if you use non-catecholamines, you may have a better outcome. I think there are problems when you put apples and oranges all into one meta-analysis and say, oh, look, there's a response. So I think it's worth breaking down and looking at the different drugs. And the most commonly used non-catecholamines are vasopressin and its analogues. Now, to remind you, it's a posterior pituitary hormone that's sort of released and in health. While you're sitting here, it's involved in osmoregulation. It is antidiuretic hormone. So binding to these V2 receptors, so you hang on to fluid. But in shock states, levels go up, and it acts then as a powerful vasoconstrictor, binding now to the V1 receptors on the vascular smooth muscle. In septic shock, there's been described a relative vasopressin deficiency, so that the levels don't rise to the higher levels that you might see in hemorrhagic shock, for instance. They're more like the normal levels, so that's why it's a relative vasopressin deficiency. But the interesting thing around is these vasopressin receptors is their distribution. There's heterogeneity between organs, but also more specifically within the kidney, that there are more V1A receptors on the renal efferent than the afferent arterioles, compared to noradrenaline, which has equal number on both the afferent and the efferent. And so the thought is that this may actually help maintain blood flow to the kidney. And it's been shown in studies here, this small trial where blinded infusion of vasopressin was added and the noradrenaline was weaned down to maintain the same blood pressure in the patients. So they had the same blood pressure, but over this 4-hour period, urine output went up with the vasopressin treatment. And again, another small sort of physiological study, 23 patients this time, where they were randomized to quite high doses of vasopressin or norepinephrine early. There was an improvement in organ function, particularly in the kidney, here where you can see creatinine has gone up over this 48-hour period. So that's the sort of physiological data around vasopressin. What about the trial data? Well, the VAST trial is 10 years old now since it reported. And they found that we saw that there was no significant difference in terms of mortality between the two groups in these nearly 800 patients that were treated with established septic shock. We did see that we were able to spare the amount of catecholamines used, so it was working as a vasoconstrictor, which we'd seen in other studies. And it was interesting that that was associated with quite a marked reduction in heart rate between the two groups. Now, whether that's simply removing some of the noradrenaline that may have some beta agonist effect, or whether it's a baroreceptor response, we don't know. But there was a reduction in heart rate with the vasopressin treatment. Now, we said there was no difference in the overall population in terms of mortality, but there was one planned subgroup analysis, was based on the severity of shock at baseline, how much norepinephrine patients were on. And you see those who were on less than 15 mics in the less severe shock group were the group that seemed to have the benefit, was statistically significant, both at 28 and 90 days. Whereas the more severe shock group didn't seem to get any benefit at all. You can see the curves overlap multiple times. Now, it was the one and only a priori hypothesis that was being tested. Unfortunately, the theory was it was the more severe shock patients that would benefit. So why was it? Well, we don't know, but interesting when you look at the heart rate according to the severity of shock, you can see that it was the less severe shock group where there was really the marked reduction in heart rate. So maybe this is contributing to why these patients were doing better. So how do we explain these subgroup effects? Well, as I said, it could be a chance finding, and certainly that was my thinking and why we needed another trial. But maybe this less severe shock patients were earlier, and it was vasopressin was better at preventing renal failure, for instance, before it established, rather than waiting for it to be more severe. Or maybe the more severe shock patients just needed more vasopressin. They were sicker, and we limited the dose, and we needed to go up to a higher dose. So that led us to devise the VANISH trial, which I led in the UK as part of the UK Critical Care Research Group's trials funded by the NIHR. And we randomized patients to get early vasopressin or noradrenaline, or norepinephrine, going up to a higher dose, 0.06 units per minute, and that had to be within the first 6 hours of the onset of shock. Now, I haven't got time to talk about steroids here, but there was some suggestion there may be an interaction with steroids. So we said once you got to the maximum of that first study drug, we then you got randomized to either steroids or not. And then if you still needed more presses, you got open label catecholamines. And our primary outcome was looking at renal failure-free days, which I'll show in a moment. And you'll see that in this trial, the nursing staff maintained the blood pressure targets as planned, equal in both groups. And despite that, we were obviously able to use much less norepinephrine in the vasopressin-treated patients. Our primary outcome, as I said, was renal failure-free days. And summarizing it here, you can look at the distributions in all the groups with vasopressin with or without steroids in the top line, and norepinephrine with or without steroids. There was no difference at all. The distributions were almost identical between the two groups. However, in the planned secondary outcomes, when we looked at the number of patients who required renal replacement therapy, we saw that it was nearly 10% lower in the vasopressin-treated patients. Confidence intervals just below 0. So it's interesting that less patients with vasopressin had needed to go on to receive dialysis or hemofiltration. But once they were on the renal replacement therapy, it didn't seem to make any difference to the duration of that treatment. And that was supported with some evidence. If we look at the serum creatinine over time, it tended to be that little bit lower in the vasopressin-treated arm. So again, some biological support behind these clinical outcomes that we had found. But it's important to look at the safety as well. And overall, we saw that the serious adverse event rate was pretty similar between the two groups. But if you look at the digital ischemia, although it's not significant, well, the confidence intervals are crossing 0, there does seem to be numerically more cases of digital ischemia in the vasopressin-treated patients. So I think there is a word of caution there. And in fact, to show you a very recent meta-analysis that I was pleased to be involved in. It's come out in JAMA just 2 weeks ago. We're looking at all the trials with vasopressin for distributive shock, so not just septic shock. Some of this is post-cardiac surgery. You see that there was a significant effect on the rates of atrial fibrillation in these patients, so lower in the vasopressin-treated patients. It looked at other secondary outcomes, including the need for renal replacement therapy. And again, when you take all the studies, confidence intervals are crossing 1, but a signal perhaps that there is less use of renal replacement therapy with the vasopressin. But again, considering the safety, looking at the digital ischemia, I think it's quite consistent across the studies. There is a higher rate of digital ischemia, it seems, with the vasopressin treatment. So what about other non-catecholamines? Well, another one that's sort of a new old drug, because it used to be available and disappeared and now becoming available again, is angiotensin II. Again, intrinsic hormones having effect on the vasculature. And you'll be familiar with the ATHOS-3 trial that reported last year. And this randomized patients to receive angiotensin II or placebo. Now, their primary outcome for this, they call it phase 3 trial because they've got their license, but I would think from a clinical point of view, physiological endpoint is a phase 2 trial, but they're looking, did it increase blood pressure at 3 hours? Well, absolutely it did, suggesting maybe a lower SOFA score with the treatment, although I think that was driven a lot by using less noradrenaline, which is obviously is part of the SOFA score. But you can see it here graphically where clearly blood pressure went up when you were given angiotensin II. It does work as a vasopressor, and they were able to spare catecholamine use. But I think we should be cautious about surrogate endpoints. We've seen this in the past with drugs that put up your blood pressure, nitric oxide synthase inhibitors. In this trial, LNMA put up your blood pressure quite clearly in a phase 2 trial. And then with the subsequent trial looking at clinical outcomes, you see that mortality went up. So a word of caution at just looking at drugs that put up your blood pressure. However, in this trial, they reported their mortality rates, and at least the point estimate is in favor of giving angiotensin II. So it's looking like it's maybe a useful drug. And again, they've reported all their safety data, and again, they're looking pretty balanced between the two drugs. So it does seem to be a safe drug, but I think we need more evidence. Because when you look at some of the other data that's in the supplementary appendix, for instance, you look at the heart rate between these two groups, actually, it was a lot higher in the angiotensin II group. Doesn't seem to be associated with a bad outcome, but it's only a few hundred patients treated. I think we need more evidence and get more familiar with using this drug before we all go away and start using it. So an interesting drug that hopefully we'll get more familiar with over time. So that's vasopressors. What about inotropes? We know myocardial dysfunction is very common, and particularly when you look at it. And as Michael Pinsky said, it's not just about cardiac output. Detailed echoes show it is very common. So should we treat it? Well, we're all familiar with Michelle Hayes' study. At the time, I was, I think, a house officer. Michael O'Leary, who was on it earlier, was a registrar at the time when this study was going on in my hospital. Where we know if we gave very high doses of dobutamine, it led to worse outcomes. So should we use catecholamines, or is there an alternative? Well, one interesting drug is levosimendan. It's an inotrope, works in very different ways. Calcium sensitizes, so you get the increased contraction without increasing intracellular calcium levels. There's no adrenergic stimulation. And so the thought is you get the increased myocardial work with minimal increase in oxygen demand. Because it's responding to the calcium that's there, you don't impair the diastolic dysfunction, which again we heard this morning is a significant problem. And you can give a single infusion over 24 hours, and because of its active metabolite, it has effects for about a week. And it's not just an inotrope, it has multiple effects, and it's thought it's been described to have anti-inflammatory, antioxidative, and anti-apoptotic effects that again may be beneficial in sepsis. And meta-analysis, again, of very small trials. There's only around just over 100 patients in total treated here, suggesting there may be a mortality benefit. But we thought that was too small a number, and we needed more data before we start using it widely. And therefore, again, another UK CCRG study funded by the NIHR, we conducted the Leopards Trial, published in the New England a couple of years ago. And we randomized patients to either levosimendan or a placebo, and looking at effect on organ dysfunction. And we saw that there was no improvement in organ dysfunction measured by the SOFA score. In fact, it actually tended to be slightly higher in the levo-treated patients than the placebo, and that was the same for the adjusted and unadjusted analysis. What that was really driven by was that we were having to use more norepinephrine. Levosimendan has vasodilating properties, so more norepinephrine was used in that treated patients, and that put up the SOFA score. But again, we saw an increased heart rate in the levosimendan-treated patients. So again, looking at the heart rate as being important. And people have said, well, that was all comers. Surely you didn't expect it to work in everybody. Well, we didn't know. It was a phase 2 trial where we were trying to decide, should we take it forward in a phase 3 trial? And could we identify the optimal population in which to study? So we did have a priori defined subgroups. According to those who had low cardiac output, we thought maybe they would benefit. If there was impaired oxygen delivery to the tissues, it measured either by SCVO2 or high lactate levels. Or maybe patients who are on high-dose catecholamines, they would be the ones who would benefit the most. And you can see there in our subgroup analysis, and it doesn't matter whether you look at the SOFA score or mortality, there didn't seem to be any group that were benefiting from this drug. So, what do? I'll give you my little summary of how I manage the cardiovascular system as far as the drugs are concerned. Norepinephrine is my first-line therapy, and if it was always going well, that's what I do. I just continue. If the dose is escalating, I add in vasopressin. I see no reason to use dopamine or phenylephrine. I rarely use epinephrine. Maybe if you feel you need some inotropy, but as you'll see later, I don't really ever think I need that. I think it makes sense if you're going to use vasopressin to use it earlier rather than as a rescue therapy. I think if you wait, you may miss the effect of the patient is dying. They're probably going to die. If you think you need to add it in earlier. And I think particularly if there's renal function is getting worse, or you've got trouble with arrhythmias, tachycardias, and so on, that's maybe when you want to start using it. I titrated up. The surviving sepsis is up to 0.03, but there's several studies we've gone up to higher doses, 0.06. I think you can do that, but a word of caution, particularly when you're using high-dose vasopressors in combination with the digital ischemia, and maybe we can accept lower blood pressure targets. I think angiotensin II is promising, but we need more evidence. And in general, and I'll talk a bit more about this in the next session, I generally try to avoid using inotropes at all. Thank you very much.